And next up, we have Professor David Edwards. Professor Edwards is a prolific inventor who has launched a number of groundbreaking technology. David explores new ways of improving human health and well-being through the air we breathe and the food we eat. His scientific and translational work principally focuses today on the pioneering respiratory droplet dynamics and the new field of airway hygiene. David was a professor of the practice of bioengineering at Harvard University in the School of Engineering and Applied Sciences. In addition to his teaching, he has transitioned to lead the startup known as FEND, a first airway hygiene product. David has received many international honors and awards. His recent book, Creating Things That Matter, won a 2018 Nautilus Book of the Year award. Professor Edwards views modern lifestyles as being in a sensory disequilibrium with an altered environment. Basic processes of living, breathing, eating, sleeping increasingly hurt us. Helping our bodies adapt in the near term is as critical as cleaning planetary air and water for generations to come. Let us listen now to Professor Edwards as he talks on airway hydration as the next human hygiene. Welcome, David.
Thank you, Laurie. Thank you so much. This has been a really incredible conference. See if I can figure this out. Which button do I have? The green. There we go. Oops. So thank you again. The record of human hygiene really threads through the history of humanity. And in fact, hygiene is something that animals do. It's something that, in a way, single cell forms of life do in their evasion of parasitical enemies. So it's not surprising that pretty much every surface of the body that has some loss of function by getting dirty has a long history of hygienic practice, which raises the question, why do the lungs, which are easily the largest surface area we have exposed to the outside environment, not have themselves a hygienic practice? Well, in fact, the delivery of clean, moist air to the gas exchange regions of the lungs is so fundamental to our ability to hydrate our bodies, actually, and oxygenate, that the lungs have created their own natural airway hygiene, as has been referred to in this in this conference. And it's a combination of mucociliary clearance, but also a really sophisticated sort of scrubbing operation that happens when air comes into the mouth and nose and passes through the larynx. Now, this natural human hygiene evolved largely with humanity in pretty humid, pretty clean air, and pretty salty air environments. And in those environments, the function has developed wherein air passes through our noses and mouths, and it passes through the larynx. Now, the larynx is the critical anatomical feature, and it has, at the narrowest passage, the glottis, and around the glottis are the vocal folds or the vocal cords, and these need to be hydrated. They're composed of high concentrations of elastin and hyaluronic acid, and when they're well hydrated, they vibrate and expand and contract. In normal breathing, normal tidal breathing, they expand and contract at about a 1 hertz frequency, opening when you breathe in and closing when you breathe out. And when you speak above a threshold phonation pressure, they vibrate at about 100 hertz. So it's an incredible anatomical feature. Now, what is less understood is that this glottal aperture plays a key role in the hydration and the cleansing of inhaled air, because as inhaled air comes through, even at normal tidal breathing, at peak inspiratory flow, you have a highly turbulent flow of air. The Reynolds number reaches about 8,000 at the peak inspiratory flow. And the high Reynolds number flow interacts with water, so the vocal folds are covered by an epithelium, which is covered by a mucus water layer. And as the air blows with turbulent force, it pulls water into the air as droplets, and those quickly evaporate as a kind of scrubbing operation. And then the turbulent air throws particles against the surface of the mucus of the trachea and the carina. Particles land on the mucus, and then cilia, which beats under the mucus. There's a paraciliar layer of water, and the cilia beat the particles to the mouth, where you swallow the particles soon after inhaling them, and that's how the lungs have developed a means of defending itself and preventing as few insoluble particles as possible from getting into the gas exchange regions of the lungs. And for most of human history, that worked really well. And so while respiratory disease existed, it was not anything near the pandemic proportions of today. Now, that requires a lot of water. We breathe out about 1/2 liter of water a day. And that water ultimately comes from the upper airways. And where does it come from? There's two sources. One is through systemic water. So osmotic forces are constantly pulling water from the systemic circulation into tissues of the body that are dry. The airways are constantly being dried out, and so the water is constantly being pulled into the upper airways. And to be clear, once you get beyond the carina, the humidity in the airways, not too far beyond the carina, is constantly at nearly 100% humidity. It's only above the carina that you have this sort of oscillating humidity. So the other place where water is coming into the upper airways is actually from the lower lungs. So the largest volume of water in the airways is actually in the alveolar region, and that water eventually comes out when you exhale, and so there's a high humidity wave of air that comes over the mucus and rehydrates the mucus. So the mucus is constantly being hydrated and dehydrated. And of course, even in the days when we were breathing constantly humid air, we would dry out. And you dry out because you're not drinking enough water, or maybe you're running and you're breathing in a lot of air, or it's just dry out. And so you begin to dry out. And what happens then? Well, your airway lining fluid, when you're evaporating more water, or it has not enough water, thins, the volume gets smaller. And what happens then? Well, a lot of bad things happen then. So the cilia then become in contact with the mucus as the mucus comes closer to the epithelial cell layer, and so they start to move more slowly. That's not good. Stresses are placed on epithelial cells, and that leads to damage, and that's not good. And we've also learned that by virtue of thinning the airway lining fluid, the concentration, of course, of salts goes up, but actually the concentration of surfactants or any contaminants that have fallen out of the air, and that means that the surface has more destabilizing elements, so surfactants and contaminants that are surfactants, as you add them, as Gerhard mentioned, as you add them to the surface of the lungs or any surface, they actually break up much more easily. Therefore, you get respiratory droplets in the upper airways, which are not good, because when you create these on inhalation, anything that's sitting on the surface of the mucus gets carried in the air and can then go deeper in the lungs, and we'll talk more about that. Now, these droplets, as we talked about yesterday, they get pulled into the air, are generally contaminants, water, surfactant, but they're generally not mucins. Mucus can get pulled into the air when you have a really strong force of like a cough, which can actually tear the mucus off. The mucus is a hydrogel. You can tear it off of the epithelial cell layer, and you can actually get mucus coming out of your mouth, but that's generally not happening when you're just normal breathing. Now, everything changed, of course, 2 centuries ago, and we began to breathe increasingly dirty air. We've been talking a lot about that at this conference. Now, the other thing that we've been talking a lot about, but that gets much less attention as far as the airways are concerned. So remember, the upper airways are kind of like a car wash. The air coming in is like a car. The water's being thrown onto the air. Particles are being pulled off. And so when the car comes in really dirty, or there's not enough water, the car leaves dirty. And so that's a big problem. Both the planet is drying out, and we're spending way more time in air-conditioned environments where the air is very dry. And so this is really challenging the upper airways from doing its normal cleaning job. So if you're in the California wildfire region and you're breathing in a lot of particulate matter, the probability of those particles getting deeper in your lungs goes up when your airways are actually not clearing those particles and they can get back into the air. And so chronic lung diseases, COPD, asthma, airborne infections have all been rising really dramatically, and so I think, as everybody knows, respiratory disease is now the #1 killer in the developing world, and it's becoming a #1, maybe the #1 killer in the developed world too. So we've been wearing masks, and Ad did a really excellent job in describing why masks work. What I'd like to talk about is there anything we can do to help the natural airway hygiene work well, even if we are in an environment that, as Dan pointed out, will probably be polluted and probably be dry for longer than we'd like. And so we've been studying, as we've been talking quite a bit about over the last 2 years, and actually goes back to my early work with Gerhard, who is really one of the pioneers of measuring respiratory droplets going back into the 1980s. And after the anthrax scare had happened, I had done work on inhaled insulin, so was brought to Washington to help figure out what to do with the anthrax scare, and led to this observation that, well, maybe we could put something in the lungs to help. And so we did this early work, and then actually a lot of work in the 2000s looking at respiratory droplets, and we'll talk more about that. But this is a pretty typical distribution of respiratory droplets. And this comes from a paper we published in PNAS several months ago. It's 150 people, and this happens to be normal subjects, but we show here that most people are breathing out many fewer than 100 particles per liter. These are all mostly particles under 1 micron in size. So I think everybody knows, but if I were to measure the particles in the air here right now, there's probably maybe 10,000 or something particles per liter, and 85% of those are smaller than a micron because the bigger particles fall out of the air eventually, and so that's exactly what you see coming out of the lungs. And most people breathe out very few. There is this group of people, and we've heard it referred to as 25% or 20% of people. There's a group of people in this room for sure who are breathing out quite a few more particles than everybody else, and the question is, well, why? And so we talk about in this paper, which was a collaboration with Chad, and he showed his non-human primate data yesterday, that, well, 3 factors that seem to correlate, and now we have much more data. Actually, Gerhard has collected more data. Age, the older you get, the more particles you likely exhale. BMI and BMI age especially. There's also this correlation. And then actually lung infection, and not just COVID-19, tuberculosis, Chad has shown. And if we can, I could afterwards talk with some people. We've done a lot of other studies in the 2000s that we didn't publish, where we saw these trends, which led us, when the COVID pandemic began, to really dig into these issues. Now, one of the common denominators of all of these conditions is that these are states of dehydration, right? And so the older we get, we lose cerebral signals that say we need water, and among other problems that lead to dehydration as you age. BMI, you have a lot more tissue to hydrate, and so you begin to lose hydration, and lung infection and just infection in general, you lose water, your membranes become leaky. And so it led us to wonder whether there might not be a hydration story here. And so I'm not going to go over all of our work chronologically. What I'd like to do is just logically carry you through and kind of answer some of these questions that we've been talking about. Where do particles come from? And I really am quite convinced that they come from both high and low in the airways. But what's interesting is that a significant fraction come from the upper airways when you normally breathe. And to illustrate that, I'm going to do a thought experiment, and then we'll look at a true experiment. So let's imagine that we go from a dry room. Let's say we're in a 10% relative humidity room, and we breathe for 2 hours the air. I measure the exhaled aerosol. Now I bring you into a humid room, and it's 40 or 50% relative humidity. What am I going to see? Well, the only thing that is impacted by you moving from a dry room to a humid room is your upper airways, because everything else is highly humid beyond the carina. So what happens? So we did that experiment and published a paper several months ago with Ad. Bax was one of the co-authors. And so people walk out of the dry room into the humid room. 10 minutes later, they're down to half as many respiratory droplets coming out. They leave the room, and about an hour later, they're back to baseline. So, well, what if I put a mask on, a cotton mask, and now I wear this mask for 2 hours, and I keep measuring this exhaled aerosol. And the exhaled aerosol was always measured in the same atmosphere. It goes down, I take off my mask, and it goes back up within an hour or an hour and a half. And so a very similar kind of, it's like I walked into a humid room. So Ad has already explained to us that masks keep humidity in the upper airways, and therefore, it's not that you're putting water in the upper airways, you're reducing dehumidification, you're reducing evaporation, and therefore the airway lining fluid is thickening out again. Now, just to review really quickly the physics, because we've talked a lot about it here, and I think it's really helpful to look that this is actually really grounded in the literature. And I'm happy to share these slides with anyone. But so there's turbulent glottal airflow that's creating stresses on surfaces that breaks up surfaces, mostly in the glottis and the trachea and maybe the main bronchi. More breakup with more contamination. There's a lot of known about surfactants and surfaces breaking up and so forth, but even with the lungs and in various mucous mimetic systems. And so what happens when you thin out the airways is there's more of the contaminants and surfactants, so you get more breakup. You hydrate. Hydrate expands the glottis. I'm going to come back to this later. This is something that's known in the phonation literature. It's not really been discussed in the respiratory droplet literature, but it's relevant. Hydration then diminishes, basically have less surfactant and contaminants, and therefore the droplet breakup goes down. So it's really simple. And so it might lead you to say, well, why can't I just put water in the upper airways? And so we have been really interested. Is there a simple way? Actually, when the pandemic began, with Bob Langer, my former advisor, went to the FDA and Janet Woodcock, and were exploring whether we could interrogate the respiratory system with a nasal aerosol. So I gave to most of you, and Gerhard, because you're not in the hotel, I'll give you one of these things that you can play around with. But basically, what this does is it creates a droplet, which is about 10 microns in size. Now, a 10 micron size droplet, if you breathe it in with a natural breath, will deposit in your nose, in your trachea, your larynx, and even to your main bronchi. It doesn't really go further than that. And so it's just a kind of a very upper airway deposition pattern. If I were to spray it in, it would all stop in the nose. But when you breathe it in, it goes there. So what you do, by the way, just so you know, you kind of hold it like this. You squeeze it. You need to breathe really deep. You do that twice. So we said, well, what if you put just water in? What would happen? And so we did that experiment, and nothing happens, actually. And so when you deliver water, it looks like there's no change, actually. Why? Because actually your airways have salt, and among other things. And so when you put just water in the upper airways, it gets pulled out quickly by osmosis, and so it's like you didn't hydrate the airways at all. So what you need to do is you put just isotonic salt. So we did this with Gerhard with full lung delivery. But if you just do upper airway delivery, actually you see just isotonic saline. It looks pretty much like the humid room. Even more dramatically if you do a hypertonic saline, because hypertonic saline then is going to be pulling more water out of the epithelial cells into the airways, so you're thickening the fluid, and so you have less surfactant and contaminants, and therefore you have a deeper, more profound effect on, but it still doesn't last very long. So if you thought, oh, this would be an interesting kind of hand washing of the lungs, that wouldn't be too useful because it would take like 20 of these a day. And so we then began to think, and actually this thinking goes back about 15 years, we began to think, well, there are different salts, obviously, in the lungs and in our body. Actually, all the salts that are in the ocean are in our lungs, and the reason is that wherever you are on the planet, you're breathing in salt that comes from the ocean because there's so much sea spray that gets ultimately up in the stratosphere, and so wherever we are, there's more when you're near the sea. Well, there are monovalent salts, the two principal ones being sodium chloride and potassium chloride, and then there's divalent salts, calcium chloride and magnesium chloride. And calcium and magnesium chloride play an important role in the airways, naturally, to clean the surface. Now, why is that? Well, they, on the one hand, then stabilize the surface. With anionic surfactants like DPPC, they have a solvation effect. There's an interaction with the head groups that lowers the chemical potential and pulls the surfactant into solution and out of the surface, which, as we've explained, actually stabilizes the surface. And then, as I said yesterday, mucus, being a hydrogel, has a thin layer of water that's constantly evaporating and being deposited from the lower lungs, very thin, that keeps an equilibrium, or tries to, with the air. And below that is mucus. And as with calcium or magnesium, there's a cross-linking that occurs that leads to a rigidification of the surface, and that actually stabilizes the surface as well. And so you might think that instead of delivering 5% sodium chloride, I delivered a 5% calcium chloride, that I might have a prolonged effect. And that, in fact, is true. And so if I deliver out of a system like this about 20 milligrams of water with about 5% CaCl2, the exhaled droplet stays low for about 5 hours. We've done a lot of these experiments over the last couple years, and the duration is about typically 4 to 6 hours, and this is magnesium chloride, so it's not an ion-specific effect. And so we've now done 7 randomized studies with a nasal saline control in different cities and countries, in very dirty environments and very clean environments. We talked about the Bangalore studies with Carol, but we also did studies that we haven't published in LA a year ago in the fall, when they had the big smoke problem, and we saw very much what we saw in Bangalore, where we had people who were breathing out 50,000 particles per liter. So breathing dry air or breathing dirty air definitely fragilizes the surface, either by thinning out the airway lining fluid, or just putting more particles directly onto the surface, and it makes the surface want to break up. Now, does it matter, right? And so it seems intuitive that as you create droplets on inhalation in your upper airways, and as I mentioned, we do see a lot of lower airway formation, particularly especially when you breathe really deep. But it seems intuitive that would increase the probability of contaminants getting deeper in the lungs. And so in the spring, and I will just say a few words about Carol's study. So in the spring, we have been, we got to people about a year ago a form of what we call FEND, and about 10,000 people have been using it in the United States, and we've learned a lot. People use it 3 times a day, morning, afternoon, and night, to keep their airways hydrated. The question is, well, what benefit does that bring? And by the way, we brought this into human testing as a nasal saline. Nasal salines in the United States are regulated as cosmetics. You need to market them as cleansers, which they are, cleaning the respiratory droplets. And so people have been using this cleansing, this airway hygiene, 3 times a day. And so Carol had been doing a study, as she mentioned, in COVID-19 patients looking at exhaled aerosol. And as other people have mentioned, Chad Gerhard, infected, you get a lot more particles. She sees that. And then when the second wave, the Delta pandemic hit, from my perspective, my dialogue with Carol, I was just really fascinated and horrified by what she went through. And I'm really glad you spoke up a moment ago about the reality that you're facing at the time. And I've said to many of you, she was hospitalized in the midst of this after having been vaccinated, was on oxygen. She lost several members of her team, died. Incredible that in the midst of that, she decided to do a random control study, really rigorous study, wherein, if it wasn't clear, 40 people came in, recently detected. If they weren't on oxygen, and they volunteered, they were put randomly into a nasal saline control group, where they took 3 times a day for 3 days, simply saline spray, or they took Fen 3 times a day. And as she mentioned, we saw symptoms go away in the FEN group, rescue therapy, steroid and antibiotic injection went down radically in the FEN group, but even more intriguingly, oxygen saturation went up. And so that led us to think, well, why would oxygen saturation? Normally oxygen saturation would be reflecting lack of permeation of oxygen in your gas exchange regions of the lungs, so what's going on. And so we all got Apple Watches and have been doing lots of studies, and now a formal study in exercise-induced dehydration. And what we find is that in addition to the respiratory droplet change on dehydration, there's a glottal aperture change, and there's an oxygen saturation diminution, which clearly happens in COVID-19 in the early stages of COVID-19, but it also happens in exercise, by the way. And if you hydrate the upper airways, as has been done now for many years for phonation reasons, for much the same reason, when you hydrate your larynx, your threshold pressure goes down, so it's easier, it expands faster and better, and that leads to an oxygen benefit. So it's a super interesting consequence. And so what I want to finish with is just to say, as was alluded to by many here, Dick did, Fan did, among others, there is a really deep literature at this point on the benefits of breathing relatively humid air and the dangers of breathing dry air for a range of central and lower respiratory tract diseases, which is, again, interesting because it's upper airways and it's having this impact on the lower airways. And so for all of those reasons, we believe that it's really critical, particularly in those regions of the world where water itself is very hard to come by, and where the air is the dirtiest, as we heard earlier, it will remain dirty and get more dirty probably for a very long time, that particularly kids who are on the planet and will be breathing planetary air longer than anybody should have clean airways. So this image actually comes from the UNICEF website, where there's an encouragement to get kids to wash their hands for the COVID-19 pandemic. And so we would argue that it's actually even more critical that they wash their airways. So thank you.